Okay, welcome everyone to the International Interprofessional Mentorship meeting. I am Dr. Kate Barlow, the founder and today's host for the meeting. It's March 4th, 2022. And today, Dr. Rebecca Hill is here to talk about tethered oral tissues. Please mute yourself during the presentation, and you can unmute yourself whenever you have a question or type your question into the chat box, and I will ask the question for you. Please, in order to get a certificate of attendance, please click on the link in the chat box. You need to complete that survey in order to receive the certificate of attendance. At the conclusion of the presentation, we will have an optional meet and greet that you are welcome to attend. Thank you all so much for coming. Rebecca, it is such a pleasure to have you today. Thank you.
Thanks so much, Dr. Barlow. I'm happy to be here. I'm happy to share some information that I have been gathering over the last several years as it relates to tethered oral tissues, most specifically tongue tie. As you may or may not know, this area has become really popular in the last decade or so. Mainly because of the increase in breastfeeding initiation rates nationally and internationally. So as more women attempt to breastfeed, this has become more of a hot topic. So there's been more research in the last decade on the topic, but still it is quite controversial. So as a background, I became interested in this area of research because of my own personal experiences with my second born child who had an undiagnosed tongue tie for the first 5 months of life. And it created a host of feeding issues for us. And I had the luxury of having already had a firstborn and knowing what's normal and what's not. So I was able to advocate for my son, but I felt really frustrated that I shouldn't have to be doing that level of advocacy, and more knowledge and awareness on this oral anomaly was really necessary for all healthcare providers and professionals so that we can advocate for the breastfeeding dyad or just an infant that's struggling to feed either at the breast or at the bottle. So a basic definition of what tongue tie is, in the research, you may read that it's a cord or it's a band. Nikki Mills and colleagues in 2019 did some cadaver research on 9 adult cadavers to disprove that. And what we know now from that research is that it is a really complex 3-dimensional structure of fascia. It's created by a thin layer of fascia, and how we determine exactly what it is by looking at the anatomy. So what you can see on this slide is a couple of black arrows. You can see that the arrow that's pointing to number 1 shows us exactly where the tongue tie inserts at the bottom of the tongue. Then we have the arrow number 2 that shows us where on the floor of the mouth to under the tongue that tongue tie inserts. And then 3, the arrow that points to number 3, is looking at the insertion of the tie to the genoglossus, or the muscle under the tongue. And then number 4 is where that tongue tie connects to the lower jaw. So if you look at arrows 1 all the way to 4, that's where you can see the actual length of the frenulum. And then these white arrows show us the submandibular ducts that every normal anatomy you would see in all the normal anatomy under the tongue. So overall, there's been a recent publication of a consensus report by MESSNER and colleagues. And this consensus was based on basically personal opinions of several experts in otolaryngology, or ear, nose, and throat physicians. And that consensus report showed us that first, these professionals, these experts in the area, are recommending non-surgical approaches before jumping to a surgical treatment of tongue ties. They also report that they do not recommend the use of any local or injectable anesthetics, either topical or injectable, prior to treatment. What's really interesting here is the upper lip ties and the buccal ties. So when we talk about tethered oral tissues, we're not talking just about the tongue tie. We're talking about the upper lip tie, also known as a maxillary frenulum, as well as buccal or cheek ties. And these have, again, really increased in identification over the last several years. But this consensus report did not find any evidence to support a standard definition of an upper lip tie. They also agreed that buccal ties or cheek ties should not be corrected or revised. What's also interesting, and again, is where we see kind of this dichotomy of opinions is on posterior tongue tie, and that will become a little bit more obvious of what exactly that means as I advance through these slides. But they did not reach agreement on what a posterior tongue tie is, or even if that is an actual thing. And they couldn't agree on exactly what type of breastfeeding problems or when these oral tethered tissues actually cause breastfeeding problems. What they did agree on is that tongue tie specifically may be a potential cause of breastfeeding issues. Now, there's been research that has shown that tongue tie causes breastfeeding issues. But again, what they couldn't agree on is exactly what type of issues there were. And more importantly is none of the research that we've seen in the last 10 to 20 years has looked at the infant, which is problematic in and of itself. If you think about these approaches and these treatments are really targeted to the infant, we need more information on how these oral tethered tissues affect the baby, not just the breastfeeding mother. So that's what I've been working on in the last 5 years or so, is looking at dyad research and the combination of maternal symptoms and infant symptoms and how those interrelate in the setting of these oral tethered tissues. So documented prevalence, this is really tricky too. We've seen prevalence rates from 0.3% all the way up to 45%. So we still don't have a great idea of how many babies these oral anomalies are affecting. In 2020, I worked on a systematic review and meta-analysis with some nurse researchers, and we found a more reliable prevalence of about 8%. That also showed us that we could, in any given study, expect to see a prevalence range from 0% to 18%. So we still don't really have a super precise prevalence, but what we do know is it's affecting a subset of the population. So we need information on who it's affecting, how do we treat it, and when do we treat it? What really we are still missing in the research is who's benefiting most from treatment of these tethered tissues. What we also have seen in the literature is that the incidence of frenotomy, or the treatment of these oral tethered tissues in the United States, has gone up almost 900% since the late 90s. So the treatment is skyrocketing, but we still don't have the robust data that we need or the research that we need to support that treatment, which is really important. And as you may or may not know, that's what really is going to guide clinical practice, is evidence-based research that supports that these tethered oral tissues are more common in males compared to females. But again, because of the variability within and between studies and the screening measures that are currently used in practice and in research, we have this still variable report on prevalence. So we really need to do a better job at using a standardized, valid, and reliable diagnostic tool. And you'll learn really soon in this presentation that we don't have one of those yet. So at this point, most of our clinicians that are assessing for these oral tethered tissues are doing so without a standard tool and maybe without formal training on how to evaluate for these tethered tissues. There was a Cochrane review back in 2017 that looked at the only randomized controlled trials that have been conducted in tethered oral tissue research. There have been only 5 to date, and there haven't been more since 2017. That is really related to, I think, the difficulty of blinding a group. It's pretty easy to tell whether or not a frenotomy was performed, so it's hard to have a control group. It's also a big issue around ethics in terms of withholding treatment if we know that the baby may benefit, especially around feeding, growth, weight gain. Those randomized control trials in all did show a short-term reduction in maternal nipple pain, and again, inconsistent effects on breastfeeding. And the reason that it only found short-term reduction in maternal nipple pain is because none of these RCTs had longitudinal data. So all of these RCTs had a control group, and in that control group, the vast majority of parents elected to have a frenotomy procedure within 2 weeks. So that's pretty telling in and of itself, but we still don't have long-term data to support, is there, from a control group standpoint, is there a significant improvement in feeding and in maternal symptoms over the long haul? So what we still don't know at this point, and I know this presentation is a lot about what we still don't know because there is a lot, the best age to perform the frenotomy. Some research and some experts in the field will say the earlier the better. So the longer that a baby is learning to feed with these oral restrictions, the longer it's going to take for them to relearn how to eat once those restrictions are treated. So many will say the earlier the better, but there's no research to support that. We don't have any data on infant pain when this procedure is performed. So that's a major limitation. Again, because we're really intervening on the baby, we need baby data. Improvements in duration of breastfeeding. So this, I think, is where we can really move the needle. Nationally and internationally, there's always a focus on increasing the rate and duration of exclusive breastfeeding. We know the benefits of breastfeeding for moms and their babies. So if we can determine that identification and treatment of these oral tissue restrictions improve the duration of breastfeeding, I think that's the data that we need to inform clinical practice, because we are all focused very much on exclusive breastfeeding for at least 6 months of life. So if we can get parents to meet that goal by reducing pain and improving infant feeding through frenotomy, then that would be really tremendous. My dissertation research, when I was completing my PhD, I had 84 mother-baby dyads, and there was a 17% increase in exclusive breastfeeding rates after the tongue tie was treated. So that's really helpful information to have. I think it's good pilot data to move to further research. But again, I think that third bullet, the improvement in duration of breastfeeding, is where we really need to target research that will guide clinical practice. There's no data on tongue tie on preterm infants because preterm infants have a host of other issues that are complicating feeding. They are more likely to have other comorbidities that impact feeding. They have a higher degree of stress response. They may have been intubated or, fed through an NG or a G tube. So all of those things complicate feeding. So it's really hard to just hone in on tongue tie or oral tissue restriction in the preterm infants. And there's very, very little data on the effect on infant weight gain or breast milk supply. So there's been one study that's looked at breastfeeding efficiency by weighing the baby before and after a breastfeeding session in 6 babies, so not a huge number. It did show a significant increase in the volume that the baby was able to take in with a feeding after the tongue tie or oral restrictions were corrected. But again, because that sample size is so small, we're not going to see a movement in clinical practice until we replicate that with really large samples. What is very important, and I think especially important to talk about here with you all as OTs, is that a multidisciplinary approach is critical to the success of not only the procedure, but infant feeding in general. So just some basic examples here of who should be involved. If you have a baby that has breastfeeding challenges, in addition to torticollis, an internationally board certified lactation consultant plus an occupational therapist are key to be involved in the care of that dyad. If a baby or toddler has articulation issues, speech language pathologists should be involved. Issues over the longer term with open mouth posture, orthodontic issues, we're looking at a combination of speech language pathologists, dental hygienists, dentists, oral facial myologists. So as you can see here, if this is allowed to continue over a longer span of time, we're going to need a greater multidisciplinary involvement, because over time, the longer these restrictions are in place, the more issues they cause. But again, the research on all of that is quite limited. Picky eater with oral motor deficits, SLPs plus OTs, and in a failure to thrive infant, we're looking at a full interdisciplinary model where we have OT, SLP, PT, and a lactation counselor. We're always thinking about the patient's age and their cognitive and functional status when we try to determine what therapies will be required to improve the feeding and the care of the infant, the child, and the breastfeeding adult. So that takes us to, how do we know if someone has tethered oral tissues? The vast majority of screening methods that are out there are really focused on the tongue tie. We don't have a lot of screening measures for lip ties or buccal ties. We have none on buccal ties. The most common ones are listed on this slide. The two that are bolded, they're bolded because they are the only two on this slide that have any sort of data on if they're valid or reliable. But again, the amount of data on that is pretty limited. But what I really want to stress here is that we need to be thinking about not just the appearance of the tongue. We need to be looking at the function of the tongue as well as the symptoms. So a lot of these screening methods are still only looking at the appearance. And what we really need to know is, sure, we can see that there's a tongue tie there. However, is the baby able to eat efficiently? And is the mom and or baby having any symptoms? And if not, what is the rationale for intervening? If the baby is gaining weight, if the baby is able to effectively remove milk from the breast or bottle, and if the mom's not having any symptoms, that's where that consensus report and most professionals in the field will say, let's wait and see. If there's no functional issue presently, let's not intervene just yet. So the CORYLLOS criteria really just looks at the appearance. So it is very limited in its ability to tell us, is this causing an actual functional problem? And it's really just looking at where that tongue tie is in the mouth and where it connects to the base of the tongue. So you can see here that types 1 and 2 are very easily visible at the tip of the tongue. And types 3 and 4 is what you're considering to be more of a posterior tongue tie. And that's where your assessment skills are really important. You won't see that when the baby just opens their mouth and cries. You'll have to actually lift the tongue to see a posterior tongue tie. KOTLOW criteria is the same. It's looking at the appearance of the tongue and where that tie is located in the base of the tongue. It's opposite of CORYLLOS. So class 3 and 4 is where you can see it very obviously when the baby opens their mouth, versus class 1 and 2 are those more posterior ties. And you can see here some examples of what that looks like. So the KOTLOW class 3 and 4, the baby really only has to open their mouth for you to be able to see this obvious restriction at the tip of their tongue. Compared to class 1, where you really have to elevate the back of the tongue to see that posterior tie. And what you can see from this picture is that posterior ties tend to be a lot thicker. The diameter in that class 1, 3, and class 4. Now, also no research on this, but the experts in this field will tell you that if there is an anterior tie, class 3 or class 4 on KOTLOW criteria, there's also going to be a posterior tie. But again, no research to support this, just practice with experts in the field who are doing, hundreds of these a year. But they will tell you that once they release this front tie on class 3 or class 4, then you'll see a posterior tie, and you really need to release both of those to have adequate function of the tongue. The lingual frenulum protocol is widely adapted in Brazil. So Brazil is one of the only regions in the world that has a requirement that all babies are screened for oral tissue restrictions before they are discharged from the hospital, or if it's a home birth, within 48 hours after birth. So this is a national initiative that they have put into place, and they are using this lingual frenulum protocol to make that diagnosis and decision to treat. So this, again, is one of the 2 screening tools that are currently available that have some validity and reliability testing. It's looking promising, but as you can see, there are going to be several pages of slides to show you what this looks like. And what's really nice about this screening is that it looks at history, it looks at appearance, and it looks at function, which is really important. So it takes all of that data into account when making a decision to treat. So here you have some basic history information, family history. So there is a hereditary component of oral restricted tissues. Breastfeeding, so fatigue during feeding. If the baby does not have adequate suck, they are going to tire more easily. They're working really hard to get that liquid out of the breast or the bottle, and they are the babies that are falling asleep during feeding or that are taking frequent breaks during feeding. Chewing the nipple is one of the symptoms that's more consistent with an upper lip tie. So if that upper lip cannot flange or open appropriately to get adequate suction, the baby then starts to bite down on the nipple rather than suck. So then they also look at sucking. So nutritive sucking during feeding. Is it rhythmic? Are there several sucks with short pauses? That's what we want to see, versus a few sucks and long pauses telling us that the baby's needing to rest. Is there coordination of suck, swallow, and breathe? Is there chewing on the nipple? And is there clicking during sucking? Now, clicking is telling us that there's an increase in the amount of air that the baby is taking in, meaning they don't have an adequate seal on the breast or the bottle to bring out that volume. Now, I do want to mention that in terms of a multidisciplinary approach, there are other things that can be causing incoordination of suck, swallow, and breathe. There could be other things that could be leading to a baby that fatigues or tires easily with feeding. So I don't want this to mean that we're only thinking about tethered oral tissues. You know, babies that have, a poorly developed suck, swallow, breathe reflex can point to neurologic issues. Easy fatigue with feeding can point to cardiovascular disease or disorders. So it's not all about the tongue tie all the time. We do want to be thinking about other things that could be leading to these issues with feeding, because there are many things that can cause issues with feeding. And then we're looking at the anatomy and the functional evaluation. So we want to see lip posture at rest. We want the lips to be closed. Mouth breathing is not normal. So why is the baby mouth breathing? Is it because they cannot adequately, when the mouth is closed, the tongue should be up against the palate. If there's a tongue tie, they can't put the tongue in the right posture, so they keep their mouth open. Again, there are other reasons for mouth breathing, but in babies, we really want to be addressing this because it is abnormal. Where is the tongue when the baby's crying? The tongue should rise and be in the midline when the baby cries. And then what is the shape of the tongue during crying or when we manually elevate the tongue? So you can see in these lower bottom portion of the slide, the tongue should rise and it should be round in shape. This heart shape is a clear telltale sign of that anterior tongue tie. And then your physical exam of actually lifting the tongue. Is the lingual frenulum visible? Is it not visible? Is it visible when we actually have to manually lift that tongue? So what you can see in that third picture is that posterior tie, that thick band. The thickness, thin versus thick, and then where it's attaching to the tongue. So again, that midline attachment versus at the very front of the tongue. So all of that information comes together to make a decision. So we look at the clinical exam scores. We're looking at sucking. We're looking at that functional and anatomy visual exam. We're also looking at the history and clinical exam together. And this provides you guidance of, based on that score, should we treat this tongue tie? So what we need now from this is data post institution of this protocol. It's coming, but I think now that this is kind of a national initiative in Brazil, we will need data to say, guess what? Babies that are scoring less than 12 are really able to thrive. There's no long-term feeding issues. The parents are able to meet their breastfeeding goals, whatever they may be. And babies with a score of 13 or above that were treated are acting similar to their peers without functional restrictions. So we need that data. The Bristol tongue assessment is just a numeric rating tool. So it looks at the tongue tip appearance. So similar to that lingual frenulum protocol, attachment of the frenulum to the bottom of the gum, the lift of the tongue when the mouth is wide open, and then how far the tongue can stick out. Now, depending on who you ask, that's not really all that important. Actually being able to protrude or extend the tongue out of the mouth doesn't necessarily tell us enough about the tongue function. But again, there's really no data to support that either way. The TABBY, or the tongue tie and breastfed babies assessment tool, is the same thing as the Bristol tool. The only difference is that now we've put it into a picture form. So the Bristol tongue assessment tool has been adapted to the TABBY to provide this pictorial explanation of how you would score that tongue restriction. And then the Hazel-Baker assessment tool. So this has been around for probably the longest time of all the screening tools. Allison Hazel-Baker developed this as part of her dissertation research. And this is one of the other two assessment measures that does have reliability and validity data. And what you can see here is we're looking at function and appearance, which is again, very important. So it's very similar to the lingual frenulum protocol. It's a little bit shorter, but we're still looking at the actual appearance of the tongue, how the tongue can lift, and then looking at, does the tongue cup around the finger when you will put your gloved finger in and the baby tries to suck? Is that entire edge, is that a firm cup along the finger? Is there peristalsis, meaning is the tongue able to move a bolus of liquid from the front to the back? And then how often are they sucking? So we're looking again at appearance and function, which is critical. I will play this video for you. I hope it works. So this video is going to show us exactly how to assess for a tongue and lip tie. Are you able to see that, Kate? Awesome.
We don't have any sound though. Should there be
There's
sound?
no sound on it, no.
Okay.
So it's just telling you with the text what you're looking, how you're assessing. So the key here is one finger at a time, gloved finger. And what's really important about this video, I'm going to pause it for just a second, is the position of the baby. So what we're doing to adequately assess for these restrictions is we're knee to knee with the parent. And then the baby's head is facing us. So kind of up against our abdomen. So we're coming at the baby from above to look at for these restrictions. And then both fingers under the tongue and pushing up towards your stomach. So that's a posterior tie. And you really wouldn't see that when the baby was just crying unless you really lifted that tongue up. And as you can see, the baby's able to extend their tongue. So not a great indicator of function. So let me go back. Can you see my slide deck again?
Yep.
There's different types of treatment options. Sometimes these terms are used interchangeably when they are actually quite different. So frenotomy is exactly an incision into the frenum tissue. Frenectomy is an actual removal of the frenum tissue. And frenuloplasty is a release of the frenulum plus a rearranging of the tissue with a closure using stitches. And then of course, there's the treatment option of wait and see. So for all of these, the major complications are bleeding, infection, scarring, damage to the salivary glands, and oral aversion. And I bolded two of these, scarring and oral aversion, because I think they are the most common side effects or complications of this treatment. Bleeding is quite minimal. Infection is quite rare, but scarring is what can lead to a tongue tie or an oral restriction reattaching. However, in practice, you will likely see various instructions given to patients. Some providers say after the tongue or the lip or the cheek is revised, you need to be stretching or massaging those wounds for 4 times a day for 6 weeks. And then other providers will say, you don't have to do that at all. And then other providers will say, you can do that, once a day for 2 weeks. There's no clear one format for post-correction care. There's no data to support stretching or massaging of the wounds versus not. So that's a really big point of contention. And with that, I will say that the more we are aggravating these areas, the greater the likelihood that the baby then develops an oral aversion to feeding, which is a huge problem. So I think we need research, we need data to support, maybe we do need to be looking and massaging at those tissues, but how much and how often, and can we get to a sweet spot where we're preventing scarring and reattachment while also preventing any oral aversions? The more we are disrupting that tissue and aggravating that baby, the more likely it is that they're not going to want anything to do with feeding, which is a huge issue. There are certainly contraindications to this treatment. Retrognathia and micrognathia, where there's a very small lower jaw or a lower jaw that is pushed or recessed far back. If we treat that tongue tie, we increase the risk of aspiration in those babies. Same with babies with neuromuscular disorders or hypotonia. If they have muscle disorders and weak musculature, if we release that tongue tie, we again increase their risk of aspiration. And while bleeding is rare, if there is a coagulopathy or a blood disorder, that would be a contraindication to treatment as well, because we don't want to increase their risk of bleeding. So here are some pictures of what these look like. So a frenectomy, again, just cutting that, and that's typically done with scissors versus a frenuloplasty. Here on the bottom, you can see that there were sutures here. This is the biggest area of when we don't ever massage the wound or stretch the wound. If there was a procedure done via frenuloplasty and there were sutures, we don't go in there. We don't stretch the wound, we do nothing because of the sutures being present. And then you can see here, the frenotomy, here's your tongue tie, and then this was most likely done with laser, if I had to guess, based on what the wound looks like. Now, what we can see here, frenectomy, frenotomy, laser versus scissors, that's another big hot topic of debate. Most places are still using scissors to release these ties. There's been these new fancy lasers created, CO2 lasers, water lasers. There's no research that tells us if one is better than the other. So the key here is releasing the restriction completely, making sure we are avoiding complications, and then assessing the effectiveness based on maternal and infant symptoms and feeding efficiency. You will hear from providers that say laser helps to cauterize the tissue, laser helps to decrease bacteria at the area. But again, there's really no data to support any of that other than the anecdotal stuff. So a couple of other things I really think is important to mention is it's not just about fixing the tie. It's about how these restrictions are affecting the dyad, which is where my research really lies and what I find to be really important of, if these things go undiagnosed and untreated and they are causing problems for the mom and or the baby, what is happening from a functional, from an emotional standpoint? So as I mentioned before, specifically to breastfeeding, there are studies that are showing that there is a higher intake of breast milk or formula post-frenotomy. But again, the sample sizes are small. Breastfeeding self-efficacy. So this is really interesting. The mother's ability to feel confident in breastfeeding. And there's been a lot of research with breastfeeding self-efficacy measures in these samples of babies with oral restrictions to say that the breastfeeding self-efficacy actually improves after the treatment of the restriction. So some may say, well, that's interesting. How do you compare self-efficacy with a functional anomaly? But I would argue that if the mother is really struggling to feed as much as they can be when these restrictions are present, they feel more confident that they can meet their breastfeeding goals when the pain is resolved. The most common symptoms that we've found to be present in moms are painful latch, nipple pain, and incomplete breast drainage. So if we think about it from a physiologic standpoint, if the baby is not effectively draining the breast during a feeding session, that is going to directly impact the maternal milk supply. And that may be one reason that moms aren't able to meet their breastfeeding goals. If the baby isn't emptying the breast, the hormones in the mom's body are not producing more milk to meet the demand of the baby, and then their supply starts tanking. Again, not much research there, but I hope to get there soon. My dissertation research did find that maternal symptoms were 141% higher before frenectomy. And again, a pretty decent number of mothers increased breastfeeding after frenotomy was performed. Sucking. So Catherine Watson-Jenna did a really cool study last year and looked at ultrasound images of baby's tongue movement pre and post frenotomy. It was just one baby. So again, we need more robust, more sample size, more babies. But what it showed was that the tongue movement before treatment was really erratic. And then immediately after frenotomy, it became much more regular, that peristalsis, that normal movement of the tongue to bring the fluid from the front of the tongue to the back and into the pharynx was really much more organized. I worked with some speech language pathologists last year on looking at non-nutritive sucking. And so basically we had a transducer hooked up to a pacifier, and that was before and after treatment of tongue tie. And what it showed was that the amplitude or the strength of the suck was higher immediately after treatment of the tongue tie, which is really interesting. The strength of their suck immediately got better. So over time would be really important data to gather. And what was also interesting about that work was that we looked at their feeding symptoms pre and post frenotomy, and they had really concerning scores on energy and physiologic stability, meaning that they were getting tired really quickly when they had that tongue tie. So that's interesting and kind of supports that lingual frenulum protocol specific asking about, are they falling asleep while they eat? Do they need frequent rest periods? There's hardly no data on bottle feeding. But the bottle feeding data that is out there suggests that babies are 3 times more likely to be bottle fed by 1 week of age if they have a tongue tie. We also have some data on concerning infant feeding symptom scores on bottle fed babies, but the sample was quite small there. Typically what we're seeing is moms and babies are coming for evaluation and treatment of tongue tie because of their struggles with breastfeeding. And those parents really want to sustain their breastfeeding relationship. So we don't have a lot of bottle feeding data yet. This is what I've been looking at most recently as the maternal experience. There are a couple of past qualitative studies that looked at stress from moms that were really wanting to breastfeed but were struggling significantly. Anxiety and frustration about the variability in provider knowledge about these oral restrictions. So again, like I mentioned earlier, we're still kind of vacillating between the experts in this field that are really trying to support better research. And there are still some providers that are saying this isn't a thing. There's no such thing as these oral restrictions. So how do we meet somewhere in the middle to say, this is a thing, it does affect some people, but we need to know who it affects and who benefits most from the treatment. Again, some anxiety around the time it took to receive a diagnosis and answers. But most parents were, anecdotally, I can speak for myself with that, with my own personal experience. It took 5 months, but come hell or high water, I was figuring out what was going on there. We also found in one qualitative study that maternal-infant bonding was significantly affected. Most of the time, the longer it took to find an answer, the greater the impact on the bond between the mom and the baby. Some new stuff that's coming out is gastrointestinal effects. So you will hear from some experts in the field that will say, if the tongue's not moving appropriately, if the upper lip is not flanging appropriately, baby's going to take in more air and develop aerophagia-induced reflux. And what we've seen in the last 5 to 10 years is that these reflux medications that babies are being put on have a lot of negative side and adverse effects that can be detrimental to growth and development. So if we can avoid pharmacologic treatment by frenotomy, great. Not a whole lot of data yet. We are seeing some significant improvement in reflux symptoms after treatment of tongue tie. We need more data. You can see that that's the theme of this presentation. We need more data. One study that I conducted last year looked at upper and lower GI symptoms, and it was really interesting that not just the upper GI symptoms, but also the lower GI symptoms improved significantly 2 weeks post frenotomy. And of the 6 babies that were on reflux medications, only 1 was still on that medication 2 weeks post frenotomy. So again, small number of people, but what's going on in the lower GI tract that could explain why these symptoms are getting better? We would expect, if they are taking in air, then they develop that reflux. But what's going on in the lower half of the GI tract? And maybe it's because they become a more efficient eater and they're taking in that fattier milk that helps grow that healthy bacteria in their gut. We don't know, but we're hoping to find that out in the next couple of years. So in terms of the key takeaways here, tongue tie is certainly one potential cause of feeding problems. But again, we need more research to better understand several areas. The infant symptoms, again, I really can't stress that enough. We're doing this intervention on the baby and we don't have any baby data. Long-term growth and feeding efficiency. How does maternal anatomy play a key role here? Not all nipples are created equal. There is certain variations in maternal anatomy that may cause feeding issues outside of tongue tie. Are moms or parents able to meet their breastfeeding goals over time? So we need that long-term data. The GI outcomes, and how can we use non-surgical approaches? And I think this is where our multidisciplinary approach comes into play. If there are feeding issues, but there's also torticollis, maybe if we fix the torticollis, we get rid of the feeding issue. Maybe we don't need a surgical procedure. And that's where you all would come in as occupational therapists. So that's it. I think that was a lot of information. I'm sorry if I flew through it, but I made my time, 7:45. Happy to answer questions. I don't see any in the chat yet, but would be happy to answer any questions I can.
I do have 2 questions for you.
Yeah.
Are any of these assessment tools free, like the TABBY?
Yep, you can find them. You can Google them. They're all available. Actually, when I was putting this slideshow together, I did Google image searches to put them in the PowerPoint.
Great. And the second question I have in my own experience is that there's been a lot of no treatment after the frenotomies, like no SLP or OT services recommended for any type of anything. And then the children are still having problems. And then I'm being asked to come in. I'm a feeding consultant, 6 months after the frenotomy. If the research isn't there, what is, in your humble opinion and expert opinion, what should be happening after these frenotomies?
So that's a really great question. And I think it's going to depend on what else is going on. I think if we were to have a universal plan to screen all babies before hospital discharge or 48 hours after birth, if it's a home birth, hospital birth, whatever, and we were able to intervene immediately, before 1 week of age, we may not need as much additional support if we can do, some very basic suck retraining. There are lots of resources, I can share them with you in the chat, about how to teach a baby how to effectively suck after this release of their tongue. So they've been, in utero, they practice swallowing for many months before they're born. And if they have a tongue tie, they're doing that in utero. They're practicing swallowing with a tongue tie. So it's not just, they're 1 week old. You have to take into account the time in fetal development that they've been practicing with this restriction. But I think for some babies, if we treat it, is the be all end all and everything goes away. But for the majority of babies, it's not just about this one quick snip. They're going to need additional support. The parent, the breastfeeding parent, is probably going to need some additional support too, as the baby learns how to latch better. And if there's any other issues around, tongue abilities, muscle tension, then we need to be evaluating that simultaneously. So it shouldn't be, we release the tongue and you're good to go, because that's typically not the case. And what we see a lot in practice is moms will say, oh my gosh, as soon as the baby latched after frenotomy, I noticed an immediate improvement in the latch. I didn't have any pain. The baby emptied my breast completely. And then what we tend to hear is 1 week later, we're back to where we were before the frenotomy. And that's because missing that support of teaching the baby how to suck appropriately and how to use that new freely mobile tongue, teaching the mom appropriate latch techniques. So it really does require some follow-up. It's not just, let's correct the tongue and move on, because it has a lot of negative consequences when you have restriction like that.
Okay, my last question that I've had. So there's a local dentist who is doing these frenotomies. And so if we are anticipating that, or we think that there's a problem, who do we refer to? Do we say, go see the pediatrician, go see your dentist? Like who do we send the mom to?
It's such a complex question. It shouldn't be. It shouldn't be a complex question, but it's going to depend on the provider's knowledge of oral restrictions. Sometimes it's a pediatrician, sometimes it's a pediatric dentist, sometimes it's your lactation consultant. I wish there was one clear answer, and I wish every specialty and every healthcare discipline had training on this, but the fact remains that they don't. So there's not one clear-cut answer. I will say that there are resources that, and I don't know internationally, I think I need to look into this more. There are resources on providers, state by state, country by country, that are more well-versed in oral restrictions, but it's not all pediatricians. It's not all pediatric dentists. It really is so variable still, which makes it really hard.
Okay, thank you. Adesela, do you want to go ahead and ask your question?
Yes, thank you. Rebecca, thank you for that presentation. I'm a physiotherapist. I'm actually not a pediatric physiotherapist, but I got fascinated during your presentation and I learned quite a bit from your presentation. I have a concern. Is there a need for babies to be assessed for the strength of their orofacial muscles? Because sometimes, again, apart from the fact that the baby has a tongue tie, we could have weakness of some of these orofacial muscles. I was just thinking if that could be included in the assessment formats for these babies. Thank you.
Thank you, Adesela. Yes, I think that it should be included. And as I mentioned when I was talking about the assessment tools, it's not just about the tongue. It's never just about the tongue, because there are certainly other things that could be going on simultaneously that are leading to issues with feeding or the symptoms that the mom and or baby are having. So it needs to be that multidisciplinary approach. You as occupational therapists know about oral muscular physiology far better than I do. And that's why we need to really rely on each other for, these assessments to say, well, yeah, there's a tongue tie, but also, the baby has really low oral motor tone, and, we need to work on strengthening that before we even think about changing their tongue anatomy. So it really does, we have to lean on each other for our own expertise to inform the process and the care of the dyad.
So Rebecca, that sort of leads into patient's question. Why does a frenotomy increase the incidence of aspiration in children with the contraindications like neuromuscular disorders?
So the thought behind that is when you release that tongue, it's still not a strong muscle. And when you have more of it available to move, it increases the risk of, moving that fluid in the mouth through the posterior pharynx inappropriately. So there's not a great coordinated, strong effort of moving that volume from the front of the mouth to the back of the mouth and through the GI tract, and can lead to aspiration.
Gotcha. Thank you. This has been so informative. Does anyone else have any last questions?
Oh, I'm sorry. Yes, Adesola, I'm sorry. Yes, I know you mentioned you're a physiotherapist. Yes, multidisciplinary approach. Absolutely.
All right. Well, thank you so much, Dr. Hill. This has been an amazing presentation, very informative. And if anyone has any follow-up questions, you can always email me, and then I will ask Rebecca and get you the answers. Thank
And
you
I just
so
put
much.
my email in the chat too. If anyone wants to reach out, I'm always happy to connect with anyone. So thank you for having me. This was great. I appreciate you inviting me here.
Thank you so much.